Can you see it?
Yes.
Okay.
Is it in presenter mode?
It is.
I mean,
Is that how
in
you're seeing it?
presentation mode?
Oh, we don't want that, correct?
No, we want it in like view slideshow. Yeah, from beginning. Okay,
Okay.
that's okay. Keep going. Let me just see if it looks like it's in presenter.
Is it showing? It's showing my screen. Hold on. Here, I got it. Okay. How's that?
Okay, start from the beginning. Is everybody? Can you go to the, is that the first slide, Jeannie?
Yes.
Okay. Hello, everybody. Welcome. Are we all on together? Jeannie?
Yes, we have participants coming in still.
Okay.
I don't know if you want to give it a minute. I'm going to stop this for a second and restart it because I don't understand.
Yeah, I understand. We got that, Stacy.
This is really frustrating me.
Jeannie, go back to the first slide.
I'm trying. I don't. So, how's that? Okay. How's
Okay.
that?
That's fine.
Right.
Okay. Hello, everybody. Welcome to the UIC Global Health Colloquium. I see that there are people still joining, but we're going to get started. We have a really exciting presentation today, and what I hope will be a great dialogue with not one, but two special guests who I'll introduce in a moment. But first, there's a few other things we need to share. UIC has a long history of working in Ukraine. This photo comes from May of 2018. You can see Tim and Dan there from School of Medicine, College of Medicine and School of Public Health. We are at the Institute of Environmental Health, and that's the co-leader of the Environmental Health Institute. This was a NATO workshop convened upon environmental health in the conflict zone. It was in a remarkable room surrounded by this amazing painter's work of battles, important battles in history. And back then we were talking about conflict, which is in the eastern part of Ukraine. I think that certainly I couldn't have imagined that things would have gotten as horrific as they are now at that point in time. Next slide, Jeannie. This is Damiano and Dan and two of the colleagues, I believe from the Global BMT program, who are working together with Damiano doing bone marrow transplant in Kiev and in a hospital that has been experiencing siege and great difficulties. And Damiano has been tracking closely, talking with Dr. Ariana, I think it is, who was here at UIC before. her efforts to support patients in the most difficult of circumstances. So I think that I show these pictures to testify to the relationships, the past and current relationships that exist between our different colleges and healthcare workers and institutions in Ukraine. We are outraged by what's happening in Ukraine, the aggression, war, human rights violations happening against the people and state of Ukraine, and we stand in solidarity with our colleagues there and with the people of Ukraine. Next slide, Jeannie. To transition, I want to share this announcement. There's a podcast initiative that's been started by Dr. Stacy Chamberlain and others in the College of Medicine called Better Together, that features different healthcare workers, academics, activists in this space, in the global health space. And you could see that there are 2 episodes out. The second episode was with Dr. Supriya Mehta of School of Public Health. So we invite you to take a look at that. Next announcement. We're proud to announce that UIC has received a D43 called the Achieve program, that we're part of a consortium led by Washington University in St. Louis, and with a couple other universities, and it's focused on addressing the research capacity gap in global child, adolescent, and family health disparities, utilizing implementation and data sciences among vulnerable populations in resource-limited settings. I know that's a mouthful, but there's a lot of important things to say there. This was just announced last week, and believe it or not, we're starting the process of recruiting folks. So this is an application, a notice of an application for a 1-year fellowship appointment for US-based folks to go abroad to do this work. And there are a lot of different countries that are participating. There's a focus in sub-Saharan Africa, but there's countries in many other countries as well. And so I invite you to apply for this or to consider applying this year, see if you're eligible, or pass it around to your networks, or to consider thinking about applying in the future. This will be ongoing for 5 years. Next one, Jeannie. And so there is also opportunities for persons in LMICs to apply as well. And they come to the United States for some time. So there's 2 applications actually. So I don't want to take more time in it, but I want you to be aware of it and reach out to us if you are interested. Thank you. We'll have that posted on our website. The College of Nursing is also involved in that as well. Next month, we have Dr. Irina Buhimchi from the College of Nursing, and she's going to be talking about global challenges in reducing maternal mortality from preeclampsia. It's World Health Day next month, and this fits with the theme of maternal and child health and World Health Day. So we're really excited about Irina's talk. The next one. And then in May, our last one for this year is a really exciting panel on reimagining mental health care for refugees and resettlement, which includes some really leading national figures in this work and some local ones too. So come and check it out. These people are on the front lines of working with Afghans and others, and it's going to be very exciting dialogue. Okay, next. I think that's it, right? Okay, so now I'm going to introduce today's speakers. First, I'm going to introduce Leo. So this is Dr. Leonardo Cubios, who I've had the pleasure of getting to know over the past couple of years because of our work together in our project on Tajikistan, for which he was a consultant. But Dr. Cubillos has been working for over 20 years in medicine, health policy, health economics, and global health. He's worked with over 40 LMICs to strengthen health systems, to improve access to care, dedicated to advancing health insurance schemes and to improve service delivery across domains of care, including maternal and child health, non-communicable diseases, oncological, and other highly expensive conditions. He completed his psychiatric residency and fellowship at Dartmouth Hitchcock Medical Center. He holds an MD along with graduate studies in business administration and marketing from the Universidad del Rosario in Colombia. He also holds an MPH in health economics from Harvard University. And he worked as a senior health specialist at the World Bank in Latin America, in India and Africa, focusing on health insurance, results-based financing, and human rights. He also worked at the Ministry of Health of Colombia, where he was the National Director General of Health Insurance and Acting Vice Minister of Health. Currently, Dr. Cubillos is the Director of the Center for Global Mental Health Research at the National Institute of Mental Health, and he also remains active in clinical practice. So I think you can see why Dr. Cubillos, or that he has a unique package of expertise, both in clinical work and policy work and economics work and research. And I think that will be clear as he speaks. He wants us to know that when he's speaking today, he's not speaking on behalf of the National Institute of Mental Health or National Institute of Health or US government. He's speaking, expressing his own opinions, sharing his knowledge. So we're really great to have you, Leo. Thanks for coming. Before you launch into your talk, I'm going to introduce another special person who we have here. This is Dr. Juan Jose Cabrera Lazzarini. And Dr. Cabrera Lazzarini is here at UIC as a visiting research professor and faculty liaison in the College of Business Administration. And he's here in part representing the Tec de Monterrey, which is a strategic partner of the University of Illinois at Chicago. And we have students and faculty from many different parts of Tec de Monterrey who are doing study abroad experiences and other exchanges here in engineering and business and allied health sciences, and hopefully one day in other health science areas as well. And Dr. Cabrera Lazzarini is an economist and professor at Tec de Monterrey. So I know some of you have had a chance to meet him. If you haven't, you'll hear from him today. He's going to say a few words of response to kick off the Q&A after Leo finishes his talk. But I also encourage you to get to know him and get to learn about the collaboration between UIC and Tec de Monterrey, which I think offers a lot to our campus as well as to their campus. So welcome, Juan Jose. Okay. So now I'm going to turn it over to Leo. Leo's going to talk for about 45 minutes, then Juan Jose for a few minutes, and then it'll be Q&A. In the meantime, I would instruct you to post questions or comments in the chat, and then we'll call on them and we'll probably invite people to speak verbally later. Leo also made the point, if people have questions of clarification during the time that he's talking, put that in the chat and we'll get to that as well. Okay, thanks again. Go ahead, Leo.
Steve, thank you so much for your invitation to you and to the University of Chicago at Illinois. It's just great. University of Illinois at Chicago, actually. It is great to be present today in this global health colloquium. Let's see, can you see my screen now?
Yes. Perfect.
Probably want to minimize. Do you see your faces here on the right, or is that not visible to you?
We see them on the right. Your slides are good. We could see it in like full-blown presenter mode, so it's good.
Great. So let me do this. All right. So again, thank you so very much. We have an ambitious agenda today. You know, when people when I share with folks that I do a little bit of health economics, the immediate reaction is, oh, so you do cost effectiveness analysis. And you know, that has always been a very interesting follow-up question when I introduce myself at the professional level. So I thought that today we could speak a little bit about health economics and what cost effectiveness is in the context of health economics, but actually put cost effectiveness analysis as a part of a bigger universe, which is, you know, health economics. So before I start, on Monday, April 26th of 1937 was market day in a town called Guernica. As any market day in Spain, in northern Spain, people were out there gathering their groceries, having fun with neighbors and family members. And all of a sudden, in the middle of the afternoon, planes, bomber planes from two countries that were living in dictatorial totalitarian regime at that time, where Germany and Italy appeared in the skies and bombed for more than 3 hours. Some sources say 3.5 hours.
Oh.
Guernica. They pounded in the town, and they killed mostly women and children and elderly. The men were in the front fighting for the Republican side of the Civil Spanish War. Pablo Picasso, who was living in France, I think in Paris at the time, painted this very, very, very famous anti-war painting, literally called Guernica. Guernica, you see it, is the pain of the mother that is losing her son. The desperate cries of people that are in pain, emotional or physical, is a tribute to civilians who died in Guernica, that have died throughout the wars in the 20th century, and that are currently dying in Ukraine. Before I continue with any discussion and presentation about health economics, I want to propose that we all take a moment of silence to honor the victims of the Russian invasion to Ukraine. Thank you very much. I have no conflicts of interest to declare today. What I will be presenting is public knowledge, along with some personal opinions. I understand that this presentation is being recorded and will be uploaded to YouTube, and in that way will become a public good, available and accessible for everyone who, you know, wants to and has access to YouTube. So 3 learning objectives for today. Again, I would like to map a little bit of the scope of health economics and some applications in mental healthcare system analysis. And actually, it's a little bit beyond healthcare system analysis, but Let us leave it there for now. Then the second learning objective is the role of economic evaluation, including cost effectiveness analysis and budget impact analysis in mental health decision making. And third, to discuss high-level critical considerations when we are performing cost effectiveness and a budget impact analysis. So what is economics? And having Juan Jose as I discussed, and it makes me a little bit, I feel a little bit blushing at this moment, but economics assumes that there are limits in resources and that we need to make choices as to how we use those resources. So when we say economics, we actually are saying multiple different things. Economics is the study of how people make choices. It's how people make decisions under scarce resources. It's the branch of science that studies behavior and decision making, and that part of behavior is behavioral economics, the newer and widely recognized recently branch of economics and psychology. But economics is also about the incentive structure that changes or influences decision making, and it is not only financial incentives. There are other different incentives. Economics is how people use values to frame decision making, and all of these five possibilities of a study plus other more are applied to societal problems with the objective of achieving efficiency, but also achieve equity. So within economics, there are a subset of economists that apply these tools to health, and those are called health economics. And health economists use health economic tools to answer a whole constellation of different questions. What explains the rise in the opioid epidemic? How does health insurance affect household financial security? How does moral hazard affect total healthcare costs? What are the drivers of rising drug prices, and why are drug prices heterogeneous across countries or within countries? For example, in the US, across different payers, for example. To what extent have new technologies driven healthcare costs? How do physician payment mechanisms affect physician behaviors? What drives or deter individuals to seek mental health care? And how can purchasers or funders choose which new technologies or interventions to fund? And within these, I think 8 to 9 questions that we've listed in this example, I want us to focus for the moment on the last one. How can purchasers choose which technologies or interventions to fund? So we can see that economics is broad, and health economics is also broad. And this is a figure that was published in 1987 by an economist called Alan Williams, and it is called the health economics plumbing line. And it kind of walks us through the different areas, macro areas where health economics operates. And it helps us, and I'm going to start in alphabetic order at the top right. Letter A, what influences health other than healthcare? What are those occupational hazards, consumption patterns, or income that affect health? We, for example, know that people who have lower income tend to have lower life expectancy. So what are the relations that make that a fact? We're going to be then, what is health and what is its value? Is another subset of questions that health economists ask themselves and have tried to answer. And that's by trying to answer that question is where DALYs and QALYs have come to play, as well as quality of life and other things that we utilize in mental health and elsewhere, the SF-36, for example. Going to see then what are the factors that influence individuals' appetite and willingness to seek healthcare. What are those elements of price, time, or other factors? And what is the relationship of principal agent between the physician and the patient, or the health system and the patient, or the government and the patient? Going to D, another area that health economics studies is what are the factors that influence the supply of healthcare? So what are the costs of productions? What does it take to financially, non-financially, to produce literally a healthcare worker, either a physician or a lay healthcare worker or a nurse. What does it take to influence their behavior through different reimbursement mechanisms? Going to then E, this is where we will focus more throughout the presentation. What are those elements that make health or could make healthcare more efficient? So it is the macroeconomic evaluation at the treatment level, and this will be cost effectiveness analysis. And between E, C, and D, these three forces of efficiency plus demand plus supply could lead us to F, which is what are those market equilibrium factors that could make a sustained efficient healthcare system. Going to F, then also economists do a lot of work on the evaluation at whole system level, from inputs, education, for example, or syringes, to processes, outputs, and outcomes. And during my years at the World Bank, we did a lot of health system evaluation, and we were more at the G level. And then H is more, it's closer to administration and policy. It's planning, budgeting, and monitoring mechanisms that will influence all the other factors, including A. So you see, the scope of health economics is very broad, but I thought putting all this into context and understanding that we will be focusing on E is very relevant. We will come back to this at the end. So we are policymakers in this hypothetical world, and we have arrived to the grocery store, and we have a budget, and we need to buy healthcare interventions for our population. So when we are informed buyers, or hopefully we're informed buyers, we are trying to make the best decisions as a function of our of the population we serve, of our principles. We don't have any other interest than to serve them. So there are a couple of very critical questions that we ask ourselves as we do especially as we're buying healthcare services and interventions. The first question is, what interventions are the most effective, right? We don't want to buy interventions that are not effective, and we tend to have a preference for those interventions that are most effective. And within the effectiveness realm are also considerations for safety, of course. But then the second question is, what interventions yield the most value? And this is a matter of efficiency, of which, there are two kinds, broadly speaking. And those of us who live in the mental health side of health systems, we tend to compare non-treatment for depression with treatment for depression and try to make decisions at that level. But the truth is that policymakers are also making decisions to fund, for example, antenatal care or fund treatment for depression. And if they do decide to fund antenatal care, so the first question, antenatal care versus treatment for depression, is allocative efficiency. And the second one, if they decide to fund antenatal care, then which kind of antenatal care is better to fund? That is a question of technical efficiency. So we will be focusing a lot on this question of value. There is a third consideration that some of you may be thinking that I am missing in this presentation. You may put it in the chat if you want. I'm not going to mention it, but it may become evident as we go through these points. So we're going to focus on value and efficiency. So this is where economic evaluation in health comes into play. Economic evaluation is a very old concept outside of health, also within health, but it went to mainstream as a result of the World Development Report of 1993 by the World Bank. And the definition is simply a systematic comparison of the costs and outcomes of two or more interventions. And according to the World Bank, or that report of the World Bank, it is, quote, it means concentrating on the interventions that offer the greatest possible gain in health per public dollar spent. And it aims to ensure that the benefits of the interventions that are funded outweigh their opportunity cost. I will go back to that point later, but it is essentially getting the best bang for the buck through a systematic comparison of costs and outcomes. So this is economic evaluation, and some of you may have seen this quadrant before, and perhaps I should have said at the beginning that I'm assuming no prior knowledge, and those of you that are familiar with this topic at different levels may find some of this content redundant. I apologize, but I thought it was better to bring everyone up to some level, and again, assume no prior knowledge. So this is a quite well-known 2x2 matrix in which we try to understand what is economic evaluation and what is not. So on the y-axis, we have the question: does an evaluation compare two or more interventions? And there is a yes and there is a no. And the x-axis at the top, it says, are both costs and outcomes measured? So if we are not comparing two or more interventions and we are not assessing both outcomes and costs, then we're doing something that could be between outcomes description or cost description. We're doing a descriptive thing. But if we are comparing two or more interventions and we are not still comparing both outcomes and cost, we could be doing an effectiveness evaluation or an efficacy evaluation or a cost analysis. And going back to that efficacy or effectiveness evaluation, that is precisely what most RCTs do, right? They are comparing two or more interventions, but only at the outcome level. They're not comparing both outcomes and costs. So that leads us to the quadrant where we have the yes and the yes. Again, an economic evaluation needs to compare both costs and outcomes, as well as two or more interventions for it to be a full economic evaluation. And within the category of full economic evaluation, there are at least 4 types of economic evaluation: cost effectiveness analysis, cost benefit analysis, cost utility analysis, and cost minimization analysis. So several types of economic evaluation, as I just said. Through this slide, I just wanted to lay out some of the major differences between these 4 types. And I would like you to focus on the 3rd and on the 5th column. The 3rd column is the one that I pasted from the article referenced before, and the 5th column is the one I created at the end. So the 3rd column is what makes different these types of economic evaluation. In all the cases, the measurement of costs is done in monetary values, dollars, pounds, or pesos, whatever you want to do, but a monetary value. But the measurement of benefit changes. So if you're doing cost effectiveness analysis, you tend to use a clinical outcome, and that is why it's easier to understand for us clinicians, right? But for example, a cost benefit analysis transforms the benefits into dollars. And you see a lot of cost benefit analysis when you're doing funding decision analysis in other sectors, infrastructure and all that, because it's simple. But it is very tricky to transform health benefits into dollars. And there are a lot of theories there. So most often than not, health uses cost effectiveness analysis, again, clinical outcomes, or cost utility analysis that uses QALYs. And then the 5th column there is what is the evaluation question that you want to answer? If you want to answer, going to cost effectiveness analysis, the following question: what is the value of 2+ interventions with the same clinical objectives? Then you should want to choose cost effectiveness analysis. But if you have different objectives, then you may want to go for QALYs, for example. So even if within mental health, if you're comparing, let's say, treatment for psychosis versus treatment for depression, presumably, unless you're using suicide as a measure of benefit, you potentially want to go to QALYs. So let's put this into a form of graph. So efficiency, bang for the buck, trying to get the most health benefit per monetary investment. So here we can see that one of the values of cost effectiveness analysis is that it allows us to rank the value of the interventions, and from the highest value to the lowest value interventions. And you can see at the moment that there is a transition here in color, and that some of these are of different width. And this is exactly what this table did in an article published by WHO last year. they actually take a measure of value. I'm going to go back to the previous slide to make it clearer. Sorry for going back. On the y-axis, you have health benefit per monetary investment. And here you see something similar. You see healthy life years per monetary investment. So what WHO did in sub-Saharan Africa, in the eastern part of sub-Saharan Africa, is to list a set of interventions and list the cost per unit of healthy life years that was acquired. And you see that, for example, population level interventions to get one healthy life year was only required to invest $0.30. But if you wanted to, for example, pay for malaria diagnostics, then you should be expecting to need to pay $100 to get one healthy life year. So it is much more efficient to pay for salt reduction strategies than to pay for malaria diagnostics. Of course, from the clinical standpoint, that doesn't make much sense to have to do those trade-offs. And I would like you to pay a little bit of attention here to the line items that are in red. I listed some line items pertinent to mental health. And you can see that mental health interventions are somewhat in the middle of the pack, or a little bit towards the end of the pack. And you see that in order to get one healthy life year, we need to, for example, if we are treating psychosis with intensive psychosocial treatment and using first generation antipsychotics, we need to pay $716 to get one healthy life year. So this is allowing us to do across conditions and across condition comparison too. Let's go back to that opportunity cost. So this is the same graph we saw earlier. We see the rank and we see health benefit per monetary investment. And the society says, well, I am willing to pay for interventions that have a certain opportunity cost. If it has less than that, then I will not pay for them. I mean, I'm going to go back one slide. A society can say, I'm not going to pay anything that is more than $500 in this table. And glycemic control and the treatment for psychosis are out, right? So this is the opportunity cost. But what is the opportunity cost in other terms? Is the maximum amount a decision maker in representation of the society is willing to pay for a unit of health outcome, because it stands for what, if he were to use that money in something else, he could potentially get more mileage out of that same amount. So he says, well, between A and B, I'm only willing to pay up until a certain threshold, because if I go beyond that certain threshold, I'm actually misutilizing funds. And you can set opportunity costs or thresholds using qualities or healthy life years.
Leo, just want to say you're halfway.
Thank you, Steve.
Okay.
Cost effectiveness thresholds are quite arbitrary, I should say. Here on the right, you see the different cost effectiveness thresholds in different countries, and you can see that they're somewhat correlated with the GDP per capita of countries. WHO recommends that the cost effectiveness threshold should be anywhere from 1 to 3 times GDP per capita, but it is not clear the basis for that. And there is no consensus in the processes or criteria to identify the optimal threshold. So here is where things start to become tricky, right? We rank interventions. We say we're willing to pay up to a certain threshold, but we are not really sure what are the technical basis for this threshold. And we're not sure either for the process to set it. So that's an important consideration. This is the only slide that has some math, but it is not with the intent to convey anything but the following. Randomized clinical trials have a primary outcome. Economic evaluations and cost effectiveness analysis do not have primary outcomes. They compare two interventions, but they do have something similar to the primary outcomes that are called single quantitative measures, so a single unit of reporting. And there are 3 different units of reporting. The most commonly used one is the ISAR, or incremental cost effectiveness ratio, and it is essentially the difference in costs between intervention A or 1 minus intervention 0, divided over the benefits of intervention 1 minus intervention 0. So that delta, both in costs and benefits, is the ISAR. It is very simple. And ideally, that ISAR should be below that cost effectiveness threshold that we spoke earlier. The other 2 single quantitative measures are just algebraic reorganizations of the ISAR. We're not going to mention them anymore, but I want you to know that those 2 exist. So if we go to the graph on the left, we see 4 quadrants. We have the option that the new treatment is more expensive and less effective than the existing one, which is quadrant number 4. In this case, the existing treatment will dominate and there is no more conversation. Or the new treatment is more effective and it is less expensive. So we're in quadrant number 2. There is no more conversation. The new treatment is dominating. But those 2 cases are not very oftenly encountered. The more common cases are that the new treatment is more expensive, but it is also more costly. So it falls under quadrant 1. And the second case that we encounter often is that it is less effective, but it is also less expensive, and it falls in quadrant 3. If during the mapping, the intervention falls under the dotted line, which is the cost effectiveness threshold, then it could all be considered by the funders or the decision makers. The slope of the dotted line is also a way to mark the cost effectiveness threshold. I want to get to an example because we've covered a lot of theoretical territory, but I want to make 2 critical points here. When we talk about economic evaluation and cost effectiveness and value, it is very important to ask ourselves the value for whom. It is different when we're talking about the value for the payer compared to the value to the society. And we will make that clearer when we get to the examples. But let me just say that they are different, and we should always ask ourselves, if someone says, oh, that intervention was deemed cost effective, your brain should immediately say, oh, cost effective for whom? And here on the graph, we see the different costs and outcomes that should be included according to the perspective of analysis. In the societal case, all costs and outcomes should be included. And for example, in the third column, or the second column, healthcare sector, well, only costs and outcomes related to the healthcare sector. So we will not, for example, include costs related to productivity losses or gains in manufacturing, because really those are not part of the healthcare sector. Those belong to the society at wide, but not to the healthcare sector. So those are excluded. So this table helps us understand which are the most commonly used perspectives of analysis and what kinds of costs and outcomes should be included. But remember, always ask yourself value for whom. And then the other question is cost effective over what period of time? Let's look on the left. So if we invest $100 now and we get a return of $100 over 6 years, well, we've received $600, we invested $100, then we could say, well, actually our profit was $500. But that is not true, because $100 6 years down the line are not the same as $500, or sorry, $100 6 years down the line are not the same $100 now. So $100 in 6 years are potentially, say, $70 now, right? So we have to discount for those periods of costs and for those health outcomes over time. So it is not a linear algebraic, a linear addition or subtraction. There should be some discounting. And so this second question is very important. First question was cost effective for whom? And then the second question is cost effective over what period of time? And for those of us working in LMICs, it is very important to note that most of the discount analysis has been done using a 3% discount rate, which is quite inaccurate for low and middle income countries. Low income countries, for example, have higher inflation rates. So the discount rate should be slightly higher. And I'll come back to this because I know I left it a little bit nebulous at the moment. So let us focus on one example. I will try to dissect this article, the Healthy Activity Program. It was published in The Lancet a few years ago. And I want to make the following caveats. This article represents a significant contribution to the global mental health field. The reflections over here convey points to assist in the conceptualization of critical elements of health economics. And the reflections, please, may not be construed as a critique to the article or its value for the field. So, first table, we see a typical RCT table. We see column 2, it's the intervention arm. Column 3 is the control arm. We see a primary outcome of back depression inventory. We see that the back depression inventory is lower in the intervention, so it potentially is more effective. And the second outcome, the depression remission rate is also much higher in the intervention. So from the effectiveness standpoint, it appears, and given the p-value, it gets a thumbs up. But this article also does some cost analysis, and it goes and asks what are the health system costs, and it looks at laboratory costs, medicine costs, hospital admission costs, and it compares them in both intervention and control or arms. But it also asks what are the productivity costs. So you see that in the intervention arm, the health system costs are higher. In the productivity arm, the productivity costs are lower. So that is indicating to us that those in the intervention arm are actually producing some savings for the society in terms of productivity costs. And then we go to health system perspective. And we see that from the health system perspective, the costs of the intervention arm was $113, and for the control arm was only $67. So from the health system perspective, definitely treating is with this intervention is much more costly, or more costly, I would say. From the societal perspective, it is slightly costlier, but not as much as from the health system perspective. So we could say that there are some societal gains that are not visible to the health system perspective. So this is perspective of analysis, right?
Leo, to interrupt briefly, someone just asked to clarify what's EUC.
EUC, it is, just take it as, I just blanked, is enhanced care, enhanced, Steve, help me here.
Usual care.
Enhanced usual care. So it is essentially regular treatment, and they sometimes give a manual to or little training just to brush some things up, but it's essentially regular care. So EUC is control arm, and EUC plus HAP is intervention. I actually failed to say that, and this may make things clear for folks. This is a trial done in India, and it compare a behavioral activation intervention delivered by community lay health workers at the primary healthcare level to treat depression. And that program is called the Healthy Activity Program. So it compares this intervention health activity program versus regular care in India, in primary healthcare centers. And sorry for not making that clear at the beginning. So intervention, it's better, but it is also costlier for the health system perspective, and it's slightly costlier from the societal perspective. And now on the third table, we have the single quantitative measure, and we see some ICR, cost per quality gain at 3 months. We see $9,000 per quality at 3 months with the confidence interval below. And from the societal perspective, it's more efficient. It's only $957. And you also see some single quantitative measures for cost per remission and cost per PDI point. So again, incremental cost effectiveness ratio measures for efficiency. And you see that this intervention, if we go back in our memories to the quadrant, it fell under the category of more effective, but more costly, right?
Leo, just to say 10 minutes.
I'm going to potentially, Steve, then skip this or go very fast through this because I would like to get to budget impact analysis. These are a subset of steps that I thought were relevant when you were making cost effectiveness analysis. This is out of my experience when I think and do a cost effectiveness or economic evaluation. These are the steps I think through. I am not going to read them, but you will have them. Step number 3, I make sure that I describe very thoroughly using flow diagrams every intervention and the control tool, and I use different tools for this. So I encourage you to do that if you are going to do a cost effectiveness analysis. And then I choose a perspective of analysis. And if you want to take one thing from, or a couple of things from this talk, is there is a recommendation to do or a standard to do cost effectiveness analysis, and it's listed as the top bullet here. It's a JAMA publication in 2016, and they recommend that we always, regardless of the cost effectiveness analysis, we do a societal perspective and a healthcare perspective analysis. And they give us a template so that we make sure that we do not forget important costs. Importantly, the panel recommends using a discount factor of 3%. Again, that is not accurate for LMICs, in my opinion. LMICs should have higher discount factors. And then we have to go through creating a cost structure, and there is a methodology called the TDABC that I use, and I'm not going to go into detail, but it's some documents that are relevant here, and you will find the citations that could be beneficial for you. So let me go back to the example of the paper published at the Lancet. So these are some of the discussion points, and I'm going to read them. The total healthcare cost per person, including the intervention cost, was significantly higher in the intervention than in the control group. Okay, well, this intervention is effective, but it needs additional funding. That is my comment. Figure 3 provides a cost effectiveness acceptability curve indicating that the intervention has an 80% chance of being considered cost effective from a health system perspective in the state of Goa in India. And in the interest of time, I'm not going to explain what is this curve, but we now know that this intervention is likely to be cost effective. Excluding the cost of intervention, the use and thus the cost of other healthcare service costs was not considered between groups. So this is a very important point. The district or health center manager bears the brunt of the costs with no cost savings. So read again, the cost of the intervention, the use and thus cost of other healthcare services costs was not different between groups. So he or she is paying for this intervention and it is not getting any savings. Health system planners will need to consider whether or not the additional budgetary costs or investments in the intervention are worth the health improvements gained. Well, my thought is, well, they may be worth, but exactly what is the amount that we need to invest? This article and cost effectiveness analysis is not making that point. We don't know yet how much is needed. The incremental costs are modest. If society is willing to pay up to the equivalent of 1 month's wage in Goa for an unskilled manual worker per revision. And I say, well, that is conceptually interesting, but it is not really practical. From a societal perspective, productivity losses due to days unable to work and work cutback are significantly lower in the intervention group than in the control group, which means that the overall costs of the intervention are no longer significant to those in the control group alone. These findings means that essentially the intervention has a 90% chance of being cost effective from the societal perspective. So my question is, so how much budget is really needed to deliver this intervention at scale? And how much of this budget is really needed to be given to the district or health center managers so that they deliver this intervention? So cost effectiveness analysis gives us an answer of value, but it's not talking about budget. You've seen this already. In the x-axis, I've put budget. And hypothetically, let's say the state of Goa is funding all the interventions up to the point of budgetary restriction. And now we have this wonderful intervention that has a lot of value. But again, if it's very wide from the x-axis perspective, it means that it needs a lot of budget. So if I re-rank my interventions, I will probably have to exclude some of the lower value ones, right? So budget impact analysis allows us to answer the question as to, okay, how much money do we need to pay for those interventions that are deemed cost effective or of high value, and can we afford it? So affordability is a different question than value. I was hoping that we could read this together. Maybe we do have time. I'm going to try to read it quickly because this abstract published in the American Journal of Psychiatry of 2011 makes the point of what budget impact analysis is. Objective, the authors assess the 2-year outcomes, cost, and financial sustainability of Medicare management intervention for community mental health settings. A total of 407 psychiatric outpatients with SMIs were randomly assigned to usual care or medical care manager who provided care coordination and education. 2-year follow-up chart reviews and interviews assess quality and outcomes as well as cost from health system and managerial perspective. So we clinicians know where this is going. Results, sustained improvements were observed in the intervention group in quality of primary care, preventive service, quality of cardiometabolic care, and different dimensions of quality. From a health system perspective, by year 2, the mean per patient cost was X, and it was less than usual care per group. With a 93% probability that the program was associated with lower cost than usual care. From the community mental health perspective, the program would break even if more clients had Medicaid. So we see that it is cost effective from the health system perspective, but from the community mental health perspective, from the people that really need to pay for this, it may not be as cost effective or affordable. Conclusions, the positive long-term outcomes and favorable cost profile provided evidence of potential value of this model. However, the discrepancy between the health system and managerial cost perspective limited the program financial sustainability. With anticipated insurance expansions under health reform, there is likely to be a stronger case for this intervention. So we can say every time we want, this intervention is cost effective. But if it's not affordable, or it's not affordable by that subset of actors that need to pay for it, it may not be adopted. Here are two methodological or some considerations between the methodological differences between cost effectiveness analysis and budget impact analysis. And I think the most important ones here are the objectives. Cost effectiveness analysis, again, wishes to compare 2 or more interventions in terms of cost and outcomes, whereas budget impact analysis only wants to do an annual financial consequences of adopting an intervention. It's a simple financial exercise. The costs considered in cost effectiveness analysis are those costs that are relevant to the perspective of analysis, and in budget impact analysis are those costs that are supported by the payer. The temporal horizon or the discount analysis is as long as we need to, and in budget impact analysis it's only 1 to 3 years, and in cost effectiveness analysis we do discount analysis. In budget impact analysis we never do discount analysis. I think this slide will help us understand a little bit more what budget impact analysis is. And Steve, I have like 2 or 3 more slides, then I'm done. Great. So budget impact analysis, we look at the following. What is the current environment? What is the total population we cover? What is the sick population we have, or the population with the condition? What is the target population that we're treating with the current treatment? What are the resources we're using? And then what is the total cost of illness that I, as a payer, are incurring, right? So those are the factors I see, and you see 4 factors there. And I compare the current environment with the new environment. What if I adopt this new technology? What will be the new population? Will there be changes in incidence, prevalence, or curing? What is the new sick population? What is the new target population? What are the new resources? And what is the new cost of illness? And I literally just do the comparison between the 2 costs of illness, the new and the old. If the new cost of illness is higher than the old cost of illness, I, as a district manager or as a health insurance company, I'm quite unlikely to do this, even if it's cost effective, unless something happens. So final points here. Let's go back to the Lancet article. And let me read these two quotes. Excluding the cost of intervention, the use and thus cost of the other healthcare services cost was not different between groups. We already read this. So the reflections are, while this intervention is likely to be cost effective for the health system, it is unlikely to be cost effective for the health manager in charge of service delivery. A budget impact analysis can help us determine what additional monetary, potentially non-monetary resources are needed on the site to deliver this intervention at scale. The second quote, health system planners will need to consider whether or not the additional budgetary costs of investment in the treatment are worth the health improvements gained. This statement as such sounds like kind of a moral statement, but it is asking for additional resources. So part of that is answered through budget impact analysis, so monetary resources, but we all know that monetary resources are necessary but not sufficient to achieve behavioral change and to provide health services. And there are lingering questions. What are the other factors affecting the supply of mental health services in the state of Goa? Manpower, how is manpower paid? And what other factors are affecting the demand of services, of mental health services in Goa? For example, understanding depression as a medical illness and treatable condition. Is there a stigma associated? So essentially giving money is not enough to influence the supply and the demand and the ultimate consumption of these services. And this is where we go back to our initial point of mental health, of health economics. We spent a few minutes on box E, macroeconomic evaluation, but we ended and went back one slide with the points of supply and demand that are also needed. And those points of supply and demand are essentially contained in boxes D and C of this figure. And that's where other parts of health economics come into play. So as a wrap up, we discussed the wide scope of health economics, including some practical applications to mental health research. We studied the role of economic evaluation, including cost effectiveness analysis in the decisions to adopt or defund technologies or interventions. We studied the role of budget impact analysis in these decisions. And I went very rapidly, and sorry for this, through some high level critical steps to perform both. But also importantly, we discussed that economic evaluation and budget impact analysis are not sufficient. They are necessary, but not sufficient conditions to advance accessibility and availability of mental health services and affordability too. Other health economic areas can, support advancing the understanding of these elements. And that's it. Thank you very much. I'm going to stop sharing.
Thank you very much, Leo, for that really clear and brilliant talk. Ooh, are you hearing me? Okay, it was frozen for a second. Thank you again for that really clear and brilliant talk. Just so everyone knows, we'll go to 1:30 in terms of our Q&A. Now I want to invite Juan Jose to say a few words to kind of begin the discussion.
Thank you, Steve. Leo, thanks for such interesting presentation. I just want to reinforce from business point of view that health entities, as all service providers, they need resources to generate value. And that's a very important question that you just mentioned. And this value is for all the stakeholders, which it should include mainly patients, of course, the health professionals, government, financial institutions, and in general, for the whole society. The main challenge, in my opinion, Leo, and I wanted to offer to the rest of the audience for discussion, is how can we help the underserved groups who has a limited access to healthcare services? And on that regard, I would like to suggest two questions for future discussion and also offer a proposal on how to address them. The first question is, what can be done to ensure that most of the generated value is captured by the patient himself or herself versus the rest of the stakeholders, right? That's the first question. Second question, how can we better empower the patient to cover a higher percentage of the costs associated with the treatment, so less resources are devoted per patient and more patients can be treated? These are the questions that social entrepreneurs look to answer, and I have been doing research on social entrepreneurship, and the main objective is to design business models that can be financially sustainable and that can be scaled up to achieve global expansion. And most of the value, as I already mentioned, should be captured by the underserved members of the society that have no access to healthcare services. If we have just 1 minute, I would like to share briefly the first holistic model I have seen on that regard, and it's in the process of being implemented. So I don't know if I can share just a quick slide. I promise I will be very brief. Can you see my slide now?
Yes.
Okay, here you can see several stakeholders associated with the treatment of a patient. The idea of this model is an NGO providing different ways of increasing the value that the patient receives in the treatment, right? And this non-governmental organization can do it in 3 ways. First of all, work with local banks by providing a collateral, right, for a loan that the patient can receive from the local bank with a preferential rate, okay? On the other hand, this non-governmental organization provides vocational training for the family of the patient, so we empower them to be able to repay the loan. And finally, of course, the local hospital also supports a percentage of the treatment. So if you see, by doing that, number 1, the value captured by the patient is higher than the rest of the stakeholders. Number 2, the patient is empowered to help with an important percentage of the cost associated with the training. And that's the only thing I just wanted to add.
Okay,
So
thank you.
we're open for questions, I guess, Steve.
Thank you very much. Why don't I first invite Leo? Do you want to reply to that, or do you want to open it up?
2 or 3 quick remarks. Absolutely. I presented value as a single and non-divisible and non-transferable concept. And in reality, it can be divided in the health system. It can be unfairly appropriated by actors. And it is true that we want to, and I concur 200%, that we want to work so that most of the value is captured by the patient. The other point I really like, Juan Jose, of the many points I did like from your remarks were how to help the demand side, how to help the patients capture that. And I think you use the word empowered. From my point of view, I think health economics has done much more work on the supply of services than on the demand. And what I showed you on your one slide is a significant and interesting approach to empower the demand through different financial considerations. So I applaud that. And I do think that those of us in mental health and outside of mental health can use different techniques within health economics and outside health economics to advance the demand of services.
Thank you. Thank you for your comments, Leo.
Damiano wants to ask a question. Damiano, can you do it verbally?
Yes. Can you hear me?
Yes.
Okay. Thank you for your presentation, Dr. Cubillos. I'm dealing with oncology, and I work in many countries. And what I see is actually that that's one of my theory, actually. Efficiency is a combination, as you mentioned, of efficacy and outcome with the value of, basically with affordability. Now, in many countries at the global health policy level, many drugs are not available, no matter how much money a patient may have. India is a clear example. There are very rich people in India. They have to go somewhere else to get treated. Cuba is an opposite example. I go to Cuba. They have the drugs that we used to have 20 years ago or 30 years ago. So I think the cost analysis is not only about the dollar or the cost for the patient, but also a national cost or national availability of medications, of treatments that may not be, for whatever reason, available, not only for the money, but for many different things. Pharma, for example, don't want to make their drugs available in some countries because they are more focused on the profit of efficacy in small studies. Any clinical trial has a very strict selection of patients that makes the drug only available for some people. So I think that I was wondering if you have any thought about just broadening up the availability, not just the cost of how much do I get for $1, but how much do I get for wherever I am for whatever the cost is.
In my mind, Damiano, thank you for your question, and it's a dilemma, right? It's very difficult to answer that, particularly because there are different scenarios across countries. But the issue of availability of medication at the point of care, whether primary or high specialized care, medications and technologies is critical, and I think it's a function of different elements, not only the interest of the manufacturer, but also the interest of the supply chain involved there, the different actors that can or cannot add markups, but also the capacity of the supply of the hospitals and primary healthcare centers to actually, appropriately transform those inputs into actual patient care. So we, for example, see several cases in which, procurement of medications is I don't want to use the word corruption, but it's inefficient for different reasons. So that affects the ultimate price and availability of healthcare. But in other cases, like vaccines, it could be also a matter of supply chain of cold chain of refrigerators. So there are different issues at hand, and I concur with you. It's much more beyond costs. It's much more beyond prices.
Thank you.
Who else has a question or a comment? I saw Rebecca posted something. Rebecca Vortman, you teach health economics. We invite you to come in if you have something you'd like to share.
Hi, thank you so much. Can you hear me okay?
Yep.
The excellent presentation, and I don't know if any of my students are on right now, but I did send the link and invited them to join in because everything you talked about today kind of ties into what we're talking about in our healthcare economics course for our Doctor of Nursing Practice students who are focusing on leadership. So great presentation, and thank you for providing this opportunity for us to attend.
Thank you, Rebecca. I will be sharing my slides with Steve, and those slides are, as far as I'm concerned, probably good.
Okay, great. Thanks so much.
This is Damiano. Sorry, maybe I have the microphone availability, so I can use it. Maybe I can ask a question to both of you, Leonardo, and I want to say, do you have any sense that in different area of the world, so we talk about Latin America, we talk about Southern Asia, or we talk about Eastern Europe, like all these models that you have and that you've studied on, how do you think the local culture, history. You were mentioning before, Leonardo, you mentioned corruption. It is the word in many areas of the world. Unfortunately, we have to, I've been working in Nigeria versus India versus South America. It's part of the culture, it's part of the system. What are the interventions that you think, looking ahead, we understand the theory, we understand the models, but what can be done at the policy, at the national level, or the global health level, as a community of scientists, as a community of global health experts, to move forward? It's not going to change in a week, but based on different areas of the world, different cultures.
Want to go ahead?
You want to start, Leonardo, and I will elaborate.
Sure. Couple of points, Damiano. Great question or set of questions. Many of these techniques are used by a field called, well, some call it health technology assessment. And there are health technology assessment organizations that are in different health systems, and those organizations are publicly funded. The prime example is NICE in England, but there are others throughout the world. So I think I'm from one standpoint, I'm optimistic that this set of techniques are more and more used and more developed and refined, and are permeating different decision making levels. However, again, going back to that dilemma of supply and demand, this is a lot of work in the supply side. I think in terms of improving access to information, access to price of care, access to, when I go to the doctor here in the US, I receive an invoice that is not itemized. I don't really know what I'm paying for. So that level of transparency at that micro encounter, but also the macro encounter, can really empower the demand and decrease those inefficiencies, whether corruption or not. So I think in healthcare, we can still do a lot of improvement in terms of transparency of information, in different types of information to decrease those efficiencies. And we can look at other industries, include their, well, not that that is the best example, but it could certainly at different levels be ahead of a healthcare industry. We can look at the financial and banking industry in some elements of, or the stock markets to see some elements of transparency there. So I think my point was empower the demand through decreasing asymmetries of information.
Okay, I agree with Leo, and I will insist. I am a true believer that we are a society. We need to play a more active role on organizing non-governmental organizations to drive the kind of models that I just shared with you. We cannot rely on the government doing all. I think we have to play a more important role. That would be my 2 cents, Damiano.
Thank you. You gave 2 excellent ideas. I think pushing for transparency as a national policy, probably as a regulatory policy, and empowering NGOs that have to be also vetted by somebody. Otherwise, I think they're both very interesting solutions. Thank you.
And if you just quickly let me add, I have seen in the new generation a lot of social entrepreneurs coming from the business majors, or new students are more interested on how can I make an impact on our society? How can I develop a business model that can be sustainable and really deliver the value for the underserved community? So I think we're in the right track. We just need to encourage them to continue that way.
Thank you.
Okay, I want to pose one question, and then we have another question. Both of these are about mental health. Oh, then we got another question. Good. So my question about mental health research is, so now we're seeing a new wave of studies, I think, like Vikram Patel's study in India, and the study that you helped us with in Tajikistan, where people are incorporating these economic models along with effectiveness. And my question, Leo, is are you optimistic that these kinds of studies will get more traction with policymakers, with donors, in terms of encouraging them to make the investment and to scale up mental health interventions, which has always been a big barrier for us in mental health in LMICs?
I'm always an optimistic, Steve. I think investment decisions by government officials and aid organizations will always be done with imperfect information. So I think putting cost effectiveness analysis on the table can reduce the amount of unavailable information. If you ask me, does it include all the information they need? I'll probably say no. We need a little bit more, like I said again, budgetary impact analysis, but we also need things to understand actually how can we translate that investment from the government or the aid organization into real care on the trenches. It's not about, pouring money. So do I think this new wave of studies is advancing the field and can convince more? Yes. Do we still have a significant territory to cover? Yes, too, but I'm optimistic.
Okay, thank you. Mary Bunn, can you ask your question? Jeannie, can you give Mary permission to talk? Are you there, Mary? You can ask it.
Okay, can you hear me now?
Yep.
Okay, great. Yes, I just put a couple, thank you so much for this really thought-provoking presentation. I work, as you can probably tell, in the area of mental health and psychosocial care. So I'm thinking very much about your insights through that lens. I was thinking about the model that Dr. Lazzarini shared and sort of trying to think about how that might be applied to mental health. I was, to be honest, struggling with thinking about people, sort of making the decision to borrow money on behalf of their mental health, especially in, poverty affected or other constrained settings. So wanted to hear your thoughts of that. One possibility I started to think about is applying that model to the training of non-specialists, which is a big cost in mental health service delivery, and which they could perhaps justify hoping to have a longer term, more sustainable employment option that came out of that training or something, but would love to hear your thoughts about that.
Yes, I can give you my opinion, and I can put you in touch with the non-governmental organization that designed the model. I didn't design the model myself. I just share as an example of social entrepreneurship. Some of the assumptions of this model, it's mainly focused on underdeveloped countries in which patients and families really struggle to make a living, and even to pay for any expensive treatment is almost not affordable. So a key player on this model, in my understanding, it's the family, the extended family, always willing to, how can I support the member of the family who's going through this disease, right? Mary, in general, I believe it's applicable for different type of diseases. And if you are interested, I can put you in touch with the NGO who designed the model itself.
Mary, you're asking, or you're posing the possibility that of empowering people through training them to training persons with mental health problems to become providers themselves?
Yeah, that's one possibility, or just thinking about the applicability of that model for training providers, non-specialist providers, which is I presume, a big healthcare cost, a big cost that contributes in these cost effectiveness analyses. And so rather than think about borrowing money to treat the disease per se, you sort of borrow money to treat the implementation conditions or to address the implementation costs that are required to deliver those interventions.
Leo, do you have any thoughts on any of this?
Two or three points, Mary. First, I hadn't thought of that option of using alternative sources of funding, maybe private funding, so that lay mental health workers can be trained and then potentially paid for over a period of time. That could be interesting, particularly if there are intermediaries who can dilute those costs. Because certain, again, I have to think more through this, but that is a very interesting idea. Certainly, you're absolutely right. When we look at the delivery of mental health services, particularly in low middle income countries, not so much in upper middle income countries, the item regarding labor, just professionals or lay healthcare workers, sometimes is prohibitive, both in terms of training as well as in terms of sustainability. And yes, we can always say, well, we're going to advocate until the government allocates the money. How long will that take, right? So are there other ways to speed up the process, which is, I think, what Juan Jose is trying to convey? Are there other ways that we can leverage public funding through some mechanisms of efficiency so that we don't have to wait until public funding is available, because in the meantime, people are getting sicker? That is, without, I guess, coming back to my first point, I think what you're proposing could be food for further thought. And Juan Jose just mentioned some social entrepreneurs, and maybe they could have some interesting ideas around that.
Thank you. Thanks so much.
Leo, one last question, and maybe you can use it to make any kind of final closing remark you'd like. Don Ziegler from the School of Public Health asks, who defines equity in these models? Question mark.
These models, for the most part, are trying to, well, particularly those that associated with value, are trying to measure efficiency. So based on that perspective, I could say that we could understand equity as to how that efficiency and how that value is allocated or is used or is received or benefits across different ethnic or income groups. So a subgroup analysis using different metrics is very important when we do these type of things. Inequity is, income inequality is very high in low and middle income countries. So I would not be surprised if much of the value is captured by high income groups within different communities. So those intra-community measures of equity are very important. My last remark, I think Abiola mentions policymaker engagement is key, hands down, is absolutely key. I will encourage you to go back through that plumbing figure and think through how alternative or different disciplines like economics, political science, anthropology can help us understand what are those factors that are preventing a good availability and accessibility of services. I am optimistic that we are incorporating neurosciences, data science, and others that can help us understand better the problems at hand so that we can serve better those we are meant to serve. Economics is just one tool among many. Thank you, Steve, again, for your invitation.
Thanks very much, Leo. Thanks very much, Juan Jose. This has been a really fascinating hour and a half. You gave a great talk and great discussions. And I think it really further encourages me, and I hope many of us, to think, to use the tools that you've put before us and to think in innovative ways and collaborate with new partners to bring together these different dimensions of effectiveness, the way we normally think about it, and equity and efficiency and economics, the way that you've presented it to us. So thanks again, very, very, what?
And budgets, don't forget about budgets.
Budget, where the dream meets reality, where the rubber hits the road, all that kind of stuff. Yeah, It's been really fascinating. Thanks again. We couldn't have asked for anything more. Thanks to all of you for participating. And again, let's remember Ukraine and do what we can to stand in solidarity with with citizens of Ukraine, and especially people in healthcare, and oppose the aggression there. Take care. Bye-bye.